Hello class, welcome to week 5. This is a brief overview of chapter 4. This week we're really covering the gamut of the healthcare system, focusing on finance, access, quality, and comparative health systems. This is still a general overview, but it really helps map out what we're going to be covering during the rest of the course. We're just going to be going more in depth on each of these topics. So the first thing you need to know is that our healthcare system is not really a system. That sounds a little strange to say, but if you think about what a system is, even if, for example, if you're working in one hospital or in a company, you might see that there are different divisions that work together in certain ways. Hopefully they meet and they talk with each other if you have a highly functioning and well-functioning company or hospital. But we don't really have that in the healthcare system. We have a number of pieces that don't talk with each other. Um, the absence of an electronic record is a good example. So we don't have a record of patients that can float around from one healthcare institution to another in a seamless way. And that's a good example of how uncoordinated we are. And this leads to all kinds of inefficiencies. We don't have clear common goals. If you look across the nation, states have different goals for certain health indicators and so on. Even though we have some national standards, we really lack clear goals that we all share and work towards. Now, when we think about healthcare finance, one of the key issues that you all should be familiar with is the fact that the U.S. is really spending more than any other country. We spend about 2.5 trillion, which is about almost 20% of our GDP. It's going to be 20% of our GDP in the future, which means that 1 in every $5 will be spent on healthcare. That should be striking to you, simply because if you looked at your own home budget and you looked at how much money you spend on healthcare, you probably would not be spending 20% unless you have a number of people with some chronic illnesses in your home. So this is a reflection of the fact that we are really overspending in certain areas of healthcare, and we're not necessarily getting a return. If given all the money we're spending, you'd think we'd be number one in most of the quality measures and most of the outcome measures, but it turns out that we are not actually number one, and in some cases we rank in the low 20s or for certain indicators like infant mortality. So we're not really getting the return on investment. And that should be important to you as a taxpayer, because a lot of the money that's being spent on healthcare is coming from your tax dollars. So it's coming from the federal government. The federal government is funded by you, of course, right? So there's no government without taxpayers. So you should be concerned, I should be concerned about how our federal dollars are being spent, and are we getting the return on investment we want? Are we keeping poor people healthy through the Medicaid program, or are we keeping our elderly healthy through the Medicare program? Are we spending the money in a way that it needs to be spent to actually have the kind of outcomes that we would like to see for our nation's citizens? So if you look at the growth of healthcare expenditures, you'll see quickly that we're definitely way ahead of the crowd with regards to growth. And this is important because if you think about the growth of wages in our country, you wouldn't see a graph of this nature. So as all of you know from your own personal jobs, your wages aren't increasing exponentially. So you don't get, a 5% increase in wages the next year, then a 7% jump, then a 10% jump. You don't see this kind of growth in your wages. So that means your wages can't keep up with the increase in healthcare expenditures, and that's why we have a number of people who are becoming bankrupt because of their healthcare bills, or facing other financial problems because of the cost of healthcare, because it's outstripping their capacity and their ability to actually pay for healthcare. And so other countries have a slower growth rate. And so one of our goals in this country, one of the policy goals that we face, is to try to bend the cost curve, try to bring down the growth in healthcare expenditures so that they're closer to the growth in wages, or at least down to the level of inflation. So inflation is usually about 3% growth each year, so there's a 3% growth in our income each year, and most goods and services go up at that rate. So if we could bring healthcare costs down to that level, it would at least be in line with inflation. Right now, it's outstripping inflation and outstripping wages on average each year. There's some variation over the last few years. Okay, so now what is healthcare finance going to look like after the Affordable Care Act? Well, we expect that more people are going to be insured, and again, our federal tax dollars are being used to cover those people. So that means that even more money will be spent on healthcare in the coming years. We hope that this will lead to better return on investment because insurance should actually help people receive care and have and improve their health status. But that really remains to be seen. Also, there are a number of people who will still be uninsured. So this 93% number is a fairly optimistic number that the authors of the textbook talk about. But this number was created before the Supreme Court opinion, which stated that states cannot be threatened with the loss of all of their Medicaid funding if they don't expand Medicaid. So what that means, it's sometimes hard to translate this information, but what that means is that states do not have to expand Medicaid. They're not forced to do it. So we're going to have some states that will not expand Medicaid, which means that there will be a number of people who are working poor who still won't have insurance, and there really won't be any good affordable option available for them in the market. Remember, the reason we're expanding Medicaid for certain populations of people is that these people really lack the financial capacity to actually cover health insurance plans, and their employers don't offer insurance to them. So they're really out of the market, and so that's why they're uninsured. They can't afford what's out there, and the market is not adjusting to offer them products that are affordable. State health insurance exchanges are a way that the federal government is actually subsidizing health insurance plans so that the working poor can actually afford some of these plans. But the state health insurance exchanges are really structured for people who are ineligible for Medicaid. So those who are eligible for Medicaid based on the Affordable Care Act, and that's an eligibility is set at 133% of the federal poverty level. We think that those people were supposed to get Medicaid, but now with this new Supreme Court decision, those people may not have to get Medicaid in some states. So that means we'll be left with a number of people who are uninsured. And then, even though we have the individual mandate for getting health insurance that comes from the Affordable Care Act, the individual mandate has a number of exceptions. It has about 8 exceptions, and one exception is based on affordability. There's another one on hardship. There's another one for American Indians and a number of other exceptions that are in there, religious exceptions and so on. So if you fall into one of those exceptions, you also don't have to get insurance, which means you may be left uninsured. So we're still going to have millions of people uninsured despite efforts to cover those individuals through the Affordable Care Act. Now, you should know that most Americans still have insurance through their employer, but there are a declining number of employers that are offering health insurance. So even that approach to financing health care is somewhat threatened. Now, financing of health care can be used to pay for direct service. So there are some cases where federal dollars are being used to actually pay directly for care. And so that it's not just paying for insurance for people, but it's actually paying for care. And here are a few examples. FQHC stands for Federally Qualified Health Centers. So these are community health centers that receive federal funds to provide care to poor people, essentially. Those people may pay some of their care, but the bulk of their care is being paid for by the federal government. So this is the federal government actually trying to provide some access to care in certain areas that are chronically underserved by putting federal funds into clinics. And these are your typical free clinics that individuals think about. Also, the military. clearly the military needs health care. They have great health care needs, especially in times of war. And so our country pays for that health care. They don't have to pay themselves. So even though we pay people to be in the military, another benefit that they get is that they have free health care benefits. There are some things they have to pay for. Everything's not covered by the military. So don't think that the military will just cover anything you want. That's not the case. There are still restrictions on what people can have covered, but most things are covered. Um, and for veterans who qualify for health insurance through the Veterans Health Administration, that's also paid for by the federal government. So these are cases where the federal government is paying for uh, picking up the tab and basically paying for the care, but also paying the providers too. So it's paying the doctors, the physical therapists, nurses, and so on, who are actually providing the care. So it really does control this. This is essentially government-run healthcare. And it's really the only example of truly government-run healthcare in our nation. So TRICARE and the Veterans Health Administration. Okay, so when we talk about access to healthcare, what we're really saying is that some people, we're talking about people's ability to actually get services that they need. So some people have trouble getting the services that they need. When we talk about access, we mainly focus on insurance because insurance is really the ticket to get into the door. So it's the ticket to actually get the healthcare services that you need, mainly because most people can't afford healthcare on their own. However, even though we spend a lot of time on insurance, just always remember that people can pay for healthcare on their own. There's no law against taking money out of your pocket and paying for your own health care. At any given point, anyone can do that on their own. You don't have to purchase insurance. Even with the individual mandate, you still don't have to purchase insurance. You would have to pay a penalty if you didn't, but you're not forced to buy insurance. It's still a product that's offered by the private market or offered by a government insurance system, but you don't have to accept it. You still have the freedom to say, no, I don't want insurance. I'm going to pay for my care on my own. Okay, and so also when we talk about access, we have to think about utilization of healthcare. So there are some people that, despite having access, so they have a large major hospital across the street and they have insurance, but for whatever reason, they don't go see the doctor. Maybe they're not interested in seeing the doctor that frequently. Maybe they don't want to deal with some particular medical problem they have. So even though people have access, sometimes they don't utilize the care that is available to them. And so just remember there is an element of choice involved in access to healthcare too, for those who actually have the choice. Not everyone has a choice, of course. So who are the uninsured in our country? The uninsured are mainly adults, but we do have some uninsured children. As you see, there's essentially about 8 million children are uninsured. That hasn't really changed much from 2008 to the present. We sort of have we have a growing, an increasing number of adults and about the same number of children who are uninsured. Now, these stats, of course, will change in 2014 when the Affordable Care Act is enacted. When the insurance provisions of the Affordable Care Act are enacted. So the Affordable Care Act, some pieces are already going and already have been enacted, but the major insurance provisions that state that people have to buy insurance and that cover most of the uninsured, those don't start until 2014, mainly because states really needed to organize themselves and prepare for all of the insurance changes that are required in order to cover these individuals. So we're expecting that Medicaid expansion and something called the state health insurance exchanges will provide much more coverage than people currently have. And so we'll see a substantial drop in these numbers. If we look at the work status of people who are uninsured, you'll see that most people are actually working. So some people think that these are just folks who are mooching off the system, who have Medicaid, for example, but these are actually working people. They have jobs. Say they're the janitor in your hospital. They may not be getting paid enough and they may or may not receive health insurance from the job. Let's say, especially if the janitor was a contractor and they're working for some company that the hospital contracts out janitorial services to. then they probably don't have health insurance, and they probably get paid minimum wage, right? So they wouldn't have enough money to pay for insurance, and so they're still hardworking folks, and so they're essentially working poor, right? And they make up the bulk of the people who are uninsured. You see that when we're talking about uninsured populations, we're talking mainly about people under 64, or, or sorry, 64 and under. And the reason why is because Medicare usually covers people who are 65 and above. There are some older people who don't have Medicare, but they really make up the minority, a really small minority of elderly people. People are covered by Medicare. Now, what are some of the other characteristics of people who are uninsured? They tend there's a disproportionate amount of people who are immigrants who are uninsured, minorities who are more uninsured, age I already talked about, location. So most of the uninsured are actually in the southern part of the U.S. and not in the northern part. That may not be obvious to you, but if you think about where immigrants are coming from and where they're going to these days, they're usually going to the southern part of our country. And you think about the poorest states in our country, those are in the southeast of the nation. So some of the poorest people, the states with the highest immigrant populations, those are mainly in the southern part of the U.S. And that's all the way across from east to west. So that includes Southern California, for example, but also includes Florida. Um, Now, what's wrong with being uninsured? Well, a lot of problems that can arise: less access to care, the care is less timely, and essentially people have they tend to die earlier because they don't have insurance. Now, not all people who don't have insurance face the same barriers. Some people are young and healthy, even though they don't have insurance, and so there's some young people who just simply choose not to get insurance because they don't want to spend their money in that way. Now, we often talk about the concept of underinsured, and so this essentially refers to the idea that people have insurance, but it's not enough to really cover their medical needs. So they lack access not because they don't have insurance, but because they don't have enough insurance. And so there are a number of factors that can affect whether or not they can actually apply their insurance to their bills. One is that cost sharing. Sometimes the cost sharing is so high. Let's say if you have to pay $100 every time you visit your specialist, some people can't afford to do that. So the cost sharing might be too high for them to actually access health care, the healthcare services they need, so that they're underinsured. There may be caps on the reimbursement that providers are receiving, and so maybe certain providers don't want to take the insurance that they have. There may be certain types of exclusions, so certain types of care that people can't receive because their insurance has now created exclusions for those different types of care. So that can lead to underinsurance too. All right, now there are workforce issues that are also related to access. And so, again, if insurance is a ticket to get in the door, but if you don't have the appropriate providers in your area, in your neighborhood, because not enough people are coming to where you work. Let's say if you live in rural Georgia and you need a cardiologist, but there's one cardiologist and it's near you, and that cardiologist is 40 miles away. So you really don't have good access. So in rural areas, people lack access to certain specialists that you're going to have more often in urban areas. And that's clearly the case depending on where you are in the country. You'll see more of this. And so in general, we have a shortage of physicians in the country, a shortage of nurses, and a shortage of some other healthcare professionals in the country. But in certain parts of the country, in rural areas and some inner city areas, you have even greater shortages. So that despite the fact that people have some way to pay doctors, the doctors just aren't there. The healthcare providers are not there because they're not interested in going to those areas, or because they don't get paid enough. So this boils down to a problem of pay and the type of people we train. We know that people who are from rural areas or from inner city areas are more likely to go back to those areas and work. So if medical schools and other health professional schools recruit those type of people, then they tend to actually go back and provide service to those areas of need. And also, the amount we pay people matters. So we have trouble getting people to go into primary care medicine because primary care doesn't pay as much as the specialists. So how much we pay people, the type of people we're training matters. What we're seeing nowadays is we're seeing more of the primary care medicine uh, jobs, or sorry, positions being taken over by other types of health professionals. So instead of a family medicine doc being in a rural area, we have actually nurse practitioners working in that rural area, and they may work with a physician, but the physician actually is not located in that rural area where they are. So this is called task shifting. So we have a shifting of the task of primary care from doctors to nurses. So that task shifting works out fairly well in developing countries, and it works well in our country in certain poor areas or rural areas because the doctors expect to get paid more, and they don't want to work in these areas where the patient load isn't as high, or they don't want to work in these areas because they just don't like the places. They're not interested in working in rural Georgia. They really want to work in Atlanta if they're going to be in Georgia. So because of their own personal preferences, many times people don't work in certain areas, even though there's great need and they can actually get paid a decent amount of money. So we have task shifting taking place where you have nurse practitioners who are more than willing to go and work in certain areas, and they like the work they're doing there. All right, and there are a number of provisions of the ACA that are focused on addressing our workforce concerns. For example, there's something called a National Health Service Corps that will be receiving more money through the ACA. The National Health Service Corps is essentially a loan repayment program. It pays back loans for nurses or doctors who go work in areas that have great need for healthcare providers. So again, if you go work in rural Georgia, you can have most of your loans from school paid off if you work there a certain number of years. And then after that, you can go work wherever you want to. So that's our nation's approach to getting people to serve in areas of great need. All right, so here's another way of looking at workforce issues. You just look at the amount people are paid. As I said before, that matters. You see the primary care is down there at the bottom. Radiologists do pretty well. They're up at the top. If you look at whether people are filling residency slots in certain specialty areas, you'll see that there's been a substantial drop in the fill rate for family practice residency programs, but an increase in the specialty programs, mainly, and you see substantial increases for pathology and anesthesiology. Pathology is essentially a field where you spend your time doing autopsies and examining tissues of patients, maybe looking at cancer, maybe looking at tumors to see what type of cancer somebody has, and so on. It doesn't involve a lot of patient care, which I think is fairly interesting about the fields that are seeing the highest fill rates and the greatest percentage of change, is that those three at the top are actually fields where you don't interact with patients very much. So that says something about the type of people we're actually recruiting into medicine, and also it says something about what we're spending our money paying for. We're paying for these really technical skills that really don't require much patient care. That's where we're putting a lot of money. So it's persuading doctors to go into those areas, sorry, medical students to go into those areas. All right, now with regards to healthcare quality, we'll talk more about this throughout the course, but the general idea is that we spend a lot of money and we don't get the kind of return on investment that we want. So our infant mortality and our life expectancy are not what you would think they would be based on the amount of money we're spending. We're not exceeding people in our outcomes the way we're exceeding them in our costs, and so that's our ongoing challenge. The textbook referred to this IOM report called Crossing the Equality Chasm. It's a report that people refer to all the time with regards to how our healthcare quality needs to change in our country, and they point out a number of factors that can change in our system, some of which we'll be talking about throughout the course. Okay, I wanted to point out that there are a number of consumer tools now available for identifying quality care. There's a nursing home tool. All of these tools are put together by the Centers for Medicare and Medicaid Services. So they survey the various institutions that receive Medicare payments and also physicians, and they assess their quality in different ways. The Affordable Care Act helped create Physician Compare. Nursing home compare and hospital compare have been around a little longer. These are all very useful tools for consumers, but it turns out that consumers don't use them a lot. For many of you, this is probably the first time that you've heard of some of these tools, but a lot of our tax dollars are going into creating these really nice databases of quality information for these various institutions so that consumers can make better choices. We think that if government helps provide this type of information to consumers, and maybe if other private organizations like Consumer Reports puts out information on quality, that people will make decisions that will force the market to change. So if people start going to the best hospitals and the best nursing homes, then those that aren't performing as well will look at those hospitals and either change their performance, or over time they will just become outcompeted, and maybe those that are performing well will actually buy out those that are not performing well, so that we'll have a better performing system overall. And we think a similar thing may happen with physicians, so that the low quality physicians will get less attention from patients, and they'll eventually either change what they're doing so that their quality can improve, or they will go work with those who are have a higher level of quality, or they'll go out of business, frankly. So these are nice tools that are available in our system. I think they're some of the more interesting tools we have for really understanding the quality of care that is available, and they're really useful to consumers, and they're free. So take a look at them and try to use some of them if you have a reason to do so. Okay, so comparative health systems. One point that we want to enforce and reiterate over and over again in this class is that the structure of the healthcare system does matter, and it can impact your quality, access to care, and outcomes that you see within your system. So if you look throughout the world, you'll see different structures, different ways of organizing healthcare systems, and definitely systems that are much more like a system than ours, not so fragmented and uncoordinated and so on. And you'll see that better outcomes are tied to certain types of systems. So we want to just reiterate that point over and over again. Now, two ways that these systems tend to differ are that the financing mechanisms vary, and the delivery mechanisms vary in terms of how much is privately controlled and how much is publicly controlled. In general, on the financing side, you'll see that most countries, including the U.S., have a dominant public component. And the reason for that is that many people fall outside of the market. So many people are not insurable for a private insurer. These are people who have chronic illnesses, but they have no money. You can imagine that insurers have a hard time covering them. It's hard to build a business model around someone who can't pay for a service and who has great needs for the service. Just imagine if your car broke down every week or even every day, which is the challenge many health insurers face, yet you don't have any money to pay for car repairs. So a third party is supposed to somehow cover your repairs. So there's no way you can build a model or a business like that. So that's what health insurers are facing. So because the need is so great, and because those people don't have the money to pay, government has to step in. So we as a nation say that, well, we don't want people to go without health care. We don't want people to die because they don't have money. And so we use our tax dollars to cover those individuals. But you can see that it's a very challenging group of people to cover. But you know, for all of us, if we're in those situations, we'd love to have someone helping take care of us, right? So that's why we as a nation agreed to do that. Now, on the delivery side, delivery of healthcare tends to be publicly controlled in most other countries. In the U.S., it's a mixture of private and public, but primarily private. Our dominant model is private. And you see private in other countries too. So it's definitely a mixed bag when it comes to delivery of care. So just realize, even when you're talking about some European nations, many people will say, well, it's all completely government run, and that's just not true. Government may be financing, well, government is usually financing most of the care in European nations, but the delivery of the care itself is not always government control. In some countries, it's completely private. For example, in Germany, for example, but there are other countries where it's completely controlled by government, and government has a lot of say in where physicians go work and nurses work and so on. All right. So if you look at Canada, Canada is a mainly publicly financed system and is a mainly privately delivered system. So providers negotiate with the public government, with the national government, to decide how much they will receive and pay for the services that they provide. The same with manufacturers. So if you want to sell a drug in Canada, you're going to have to you're going to have to negotiate with the national government in order to decide how much you're going to pay for your drug. So that's very different from the U.S. We don't do that right now. Some people have tried to advocate for the U.S. to do that, but currently we don't do that. All right. And if you look at Britain, Britain is all public for the most part. It's publicly financed and it's publicly delivered. So the federal government, or not federal government, but their national government has a lot of control over where practitioners work. So where they serve. So you don't have a lot of gaps in service in a place like Britain because it is controlled by the government. The government can see where the need is, and they can send people out to fulfill those needs if those people want to work in the national healthcare system. There are some private providers, so there's still people out there who get paid in cash, for example. But they're outside of the national healthcare system, or they may work partially in the national health system and partially outside of it in a private role. But the dominant model in Britain is a national health system model, and it works fairly well, even though they're facing increasing costs too, just like most developed nations. So that's it for this time. I know there was a lot. That was fairly long. It wasn't as brief as I would like for it to be, but there was a lot to cover for this chapter. And next week will probably be shorter. So, just contact Professor McDonald or I if you have any questions about this material, and we'll have a discussion assignment this week, so we'll get a chance to spend more time talking about these issues. Okay, have a good week. Thank you.